Sudden cardiac death syndrome within football is considered the leading cause of death occurring on the field. It occurs due to an increased adrenergic drive combined with an altered anatomical and physiological variables. In football, due to the high intensity, the most common mechanism has been seen to be abnormal thickening of the septum of the heart. According to the literature, it is seen to affect 1 out of 500 individual sportsmen. Unless diagnosed or seen to have degenerative heart problems, sudden cardiac arrest occurs without any warning, ultimately stopping supply to vital organs, allowing incident to take place. During initial sudden cardiac arrest on the field, the first point of call is to ring 999 if the ambulance services aren't already at the game. Once called, the assessment of the danger of the scene is then assessed. Immediate danger occurs in the forms of the players and to self. Once referee has confirmed the game has stopped, the players then allow access for the team to proceed to the incident with sufficient space. In recent studies, since a vast occurrence of sudden death syndrome has come to light, emergency action plans within teams have been seen to be put into place to improve time taken to initiate vital care to patient. Even if the rules of the Federation of Football Association have to amend, including the referees. Once the environment is deemed safe, team can proceed to assess patient and immediately take C-spine control, either side of the head and the neck, to secure from further damage. The response phase of look, listen and feel are then commenced. Any occurrence that patient has blocked airways appears through noises such as snoring. Jaw thrust is then enhanced to open airways. On first appearance, if any signs of possible fragments of tooth or foreign objects are visible, with forceps, removal is advised. However, if too deep, this could push further down the esophagus and occurring the airway. Possible occurrence of gag reflex could also happen. Once damage phase is completed, the response phase can then take place through the use of the acronym AVPU, speaking to patients to see if any response is raised, and if unresponsive, then performing stimulus of a pain of a trapezium squeeze is then used. This is 5 centimeters from the trapezius muscle, where the head meets the shoulders. If no response, patient is therefore completely unresponsive. Often in previous cases of sudden death syndrome within football, it has been presumed it to have occasional gasping, which in turn is interpreted as breathing. This could be due to delayed recognition by first responders, presumption of seizure-like activity, or involuntary myoclonic movement. It is often reported in over 50% of athletes. Incident therefore looks as though patient is unconscious, as it appears they are breathing when looking along the chest at floor level. Research has shown that now, when entering any scene of collision or event, to always assume cardiac arrest, allowing team to prepare for the worst. If no response, once AVPU is established, a bag valve is then used to supply help to patient to breathe with oxygen supply. Check of pulse at carotid artery within the circulation phase is needed. Reasoning for this is due to it originating closest to the heart and easiest access. However, Lapistol states that assessing pulses in an unconscious patient is a challenge prior to beginning CPR. Therefore, healthcare providers should follow guidelines from Resuscitation Council, which forego the pulse check prior to commencing CPR. If unresponsive, CPR is then commenced. However, the radial artery is also deemed vital to check due to its indication of internal bleeding. If no response to all of A, B, C, cardiopulmonary resuscitation is then performed. Moving the athlete to a different location may delay the resuscitation and could lead to worse outcomes. Medical personnel should be prepared to quickly remove protective padded clothing or other equipment that may impede the initiation of CPR. This may require specialised tools or equipment. Chest compressions should be within an interlocked finger position, making sure they are off of the ribs. Arms are straight to allow pressure vertically onto the breastbone at 5 to 6 centimetres. Throughout literature, this measurement varies between 4 to 7 centimetres, providing that there are no set guidelines as time is vital and realistically isn't going to be measured, ultimately proving no reliability. This is seen to be repeated 30 times. This variable is consistent and highly reliable source with no variance throughout the literature, and is seen within healthcare, throughout sport and hospital-based environments. The 2 rescue breaths in between the bag valve show research have shown is not required, as they are seen to stop electrical current going to the heart by stopping when chest compressions could be a continuum. A recent study in 2017 by Noor et al. Has since provided evidence in partnership with National Heart Institute that the benefits are minimal and compressions with pauses for ventilation are due to importance of blood flow and oxygenation. A continue of analysis to gain additional insight are being undergone for future references. If correct equipment such as the bag valve is available, this is advisable and safest point of call of equipment, as vomit within the airway may exhibit during the 2 rescue breaths, deeming unsafe. Whilst chest compressions are a continuum on the field with the defibrillator, it is attached with the sternal paddles. These are placed just to the right of the upper sternal border below the clavicle, and the other paddle is to the left of the pectoral with the centre of the electrode in the middle axillary line. These guidelines were published by the International Liaison Committee of Resuscitation, which should see those of the European Resuscitation Council. However, these guidelines still vary throughout incidents and need greater research for reliability. Incorrect paddle placement will result in a greater percentage of the current passing through non-cardiac tissue and will reduce the chances of success. When applying the pads of the defibrillator on any wet, sweat or excessive chest hair, it has been seen to make it problematic for adequate defibrillation attachment. The necessity of using a towel and disposable razor is paramount to secure appropriate level of electrical current. Upon placement of pads, checking of any forms of pacemaker or implemented cardioverter defibrillator are vital, with it being at least 2.5 centimetres away from scar box tissue, as per international guidelines. Once applied, chest compressions are continued throughout with rescue breaths. Once shock is in place, the defibrillator assesses for charging if a shockable rhythm is present. Chest compressions throughout this phase continue, as it has been assessed that stopping can lose valuable time, leading to a 10% decrease in shock success. The internationally recommended target from the International Liaison Committee on Resuscitation from collapse to shock is 3 to 5 minutes. The success of early defibrillation in young athletes with sudden cardiac arrest has been demonstrated in a recent report by Dresner et al., showing a 64% survival rate in high school athletes with sudden cardiac arrest, treated promptly by an on-side defibrillator. Consequently, it must be recommended that in order to defibrillate a player with sudden cardiac arrest on the football field, it should be aimed for a 1 to 2 minutes collapse to shock time goal. However, external factors such as kit availability can be dependent upon this. External chest compressions must resume immediately after every defibrillation shock, with team at arm's length away each time of shock, then continuing for a minimum of 2 minutes before the rhythm analysis is repeated, as per international guidelines. Throughout considerations of changing roles within the team members, after 2 minutes of external chest compressions, it will ultimately allow fatigue to kick in. By enabling the use of the stronger members within the team on chest compressions, it will allow a greater period of time. Upon collapse, a great risk of spinal injury is placed upon patient. Therefore, constant C-spine control is assumed until use of appropriate rigid head device or blocks can be used to immobilize the neck with correct pressure to reduce any forms of long-lasting injury. Upon transfer to ambulance, it is deemed necessary for ambulance to be able to access pitch to avoid any delays in resuscitation or sudden compressions to be needed once on the stretcher. Transfers are of high risk and often result in lack of effective chest compressions when patient is fixated to a rigid device, comprising success. It is considered upon transfer that at least 3 cycles of compressions and defibrillations, as per guidelines, should be undertaken. Throughout intermediate scenario, it is paramount to keep up to date equipment, as changes on guidelines of rescue breaths and defibrillations are constantly changing through research in coming years. It is imperative that continuous treatment without delays is effective and efficient until a cardiac rhythm is assumed and signs of life are visible.